will discuss on the management of a patient with SVT. We know that the SVT are usually a narrow QRS with a QRS duration of less than 120, and they are most of the time regular, because the irregular SVTs are, we know, are the atrial fibrillation, atrial tachycardia, atrial flutter with variable conduction, and multifocal atrial tachycardia. So this group also will discuss the management separately, but more commonly the SVTs, the regular, are the AVNRT and the others. So what is, we have to see if there are visible P waves. So most of them have a negative P wave or an inverted P wave in the inferior leads. So if the P wave is visible, then it's a different direction. However, with P wave means the RP is very less than 70 milliseconds. That means we are dealing with a patient with AVNRT, that is AV node reentrant tachycardia, because the P wave is not seen or they are less than 70 millisecond of RP. If the P wave is visible, then we have to see if the atrial rate is more than the ventricular rate. So if the atrial rate is more than ventricular rate, it means it has to be from the atria. So it is either a atrial flutter or a atrial tachycardia. So we'll come to it. However, if the atrial rate is not more than the ventricular rate or atrial rate is equal to ventricular rate, then we should see whether the RP is less than PR or more than PR. If the RP is still less than PR, we can still have AVRT and AVNRT. So in AVNRT also there sometimes can be an inverted P wave seen in lead 3 and V1, which is known as pseudo S in lead 3 and pseudo R in lead V1, and that is goes with the diagnosis of AVNRT. However, if you are able to see a clear-cut RP or a clear-cut P wave, then it is usually called as AVRT and atypical AVNRT, because the typical AVNRT usually the P wave is not seen or it is just buried in the QRS. So it's an atypical AVNRT where the RP is usually more than 90 millisecond or 80 millisecond, and sometimes the atrial tachycardia. Most of the atrial tachycardia are usually long RP tachycardia, but very rarely they can be short RP. So when you go to long RP tachycardia, the typical diagnosis will be inappropriate sinus tachycardia, atypical AVNRT. Sometimes the AVNRT can have a RP which is more less than which is more than the PR. So it is known as a very atypical AVNRT or a atypical AVRT, which is also called as a paroxysmal junctional reciprocating tachycardia. Usually seen in a pediatric population, they present with tachycardia induced cardiomyopathy. So it's not much seen in an adult population. And then we can have a atrial tachycardia, as I already discussed last time. The atrial tachycardia can be focal atrial tachycardia, multifocal atrial tachycardia, intra-atrial tachycardia, or a SA node reentrant tachycardia, which we'll go to in a brief today. And then the atrial tachycardia, usually we have a, most of the time they have a regular RR interval. Very rarely the RR can be irregular, but they have a varying PR interval. They have varying PR interval and they have different morphology of P waves. And one important thing is that the P wave morphology is different from that of the sinus rhythm. So these are important things which tells about the ECG findings of atrial tachycardia. They can be from the right atrium and they can be from the left atrium. As I already discussed last time, we should see the morphology of P wave in lead V1. If it is from the left atrium, the V1 is usually positive. Why? Because the focus, it will go from the left to the right and V1 is towards the right. That is why it is positive in V1. Whereas the right atrial tachycardia, because it is going away from this direction, that is why it is negative in V1. So this is something which you should know about. Now, before going to the individual diseases of SVT, you should every time know if a regular QRS tachycardia. So all of you would have encountered a SVT in your emergency or a trauma triage. So most of the patient, young female or young male, present with regular narrow QRS tachycardia with a rate of 200. And most of you will be thinking that first thing I have to give is IV adenosine. But you should always think that before giving adenosine, you should do some vagal maneuvers like a carotid sinus massage. So that is very effective, and most of the time, 70 to 80% of the time, it reverts with carotid sinus massage. So when you give a carotid sinus massage, you should put your one of the thumb or 3 fingers in the around the carotid artery, and then you have to give it gently. You have to roll your fingers in a clockwise or anti-clockwise direction, and you should give it for around 10 to 20 seconds. If it fails on one side, usually you should do it on the other side. So after doing a right, you should always try on the left side. They say the efficacy of left carotid sinus massage is usually more than the right, because the sympathetic usually is more triggered or initiated on the left side. So you should do always on the both side. Some people also tell that you can do a oculocardiac reflex, where you can roll around and give a gentle massage around the eyeball on both the side. However, that is not much effective. Their recent publications have also come with a modified Valsalva manner, where once the patient has to sit, and when he does the Valsalva, you have to immediately make the patient lie down. So they say that the efficacy of modified Valsalva is more than the Valsalva manner. So some of the time when the patient has a SVT, we usually teach them how to do Valsalva, because if they get an episode of SVT at home they can try the Valsalva manuals, and which is very effective, so that it can terminate even at home. So only if these manuals are not working, then you have to see if the patient is hemodynamically stable or unstable. Most of the time the SVTs are usually stable unless their rate goes more than 250 to 300. So most of the time they are stable, and they have to be first managed with IV adenosine. So when you give adenosine, you have to give usually the first dose of 6 milligram. Ideally the adenosine has to be given from the peripheral central line. So if you do not have a central line, you give peripheral line, but make sure that as soon as you give adenosine, you have to give a fast saline flush and raise the hand of the finger, so that it is, because the half-life is very short, it has to go fast into the circulation. Fast, you have to raise hands so that all the adenosine go into the circulation very quickly. If with one bolus of 6 mg doesn't revert, you can try again a next bolus of 12 milligram of adenosine. Most of the time, 90 to 95% of the time, the AV NRT respond to at least the adenosine, and 90% lesser than the AV NRT, the AV RT respond to the adenosine. So around 18 milligram of adenosine is the maximum dose which you can use safely. There are some side effects of adenosine, like the patient may have a transient asystole lasting for 5 to 6 seconds, but usually it is very transient and usually comes back to the normal. The patient may get a feeling of very high breathing, abnormal breathing, because of the adenosine usually acts on the receptors are very different where your all other things work. So they can cause a sudden transient bronchoconstriction and all. So if the patient does not respond to the adenosine, next you have to give is IV beta blocker. We know various beta blocker can be tried, like the metoprolol 5 mg boluses or the esmolol. So esmolol can be tried, or IV metoprolol can be tried. Next, if the patient even does not, only if the patient is hemodynamically stable, you have to try all this. Next, we usually ideally should be tried on diltiazem or verapamil. We know that both these drugs IV are usually not available in our emergency many a times. However, if it is available, diltiazem is the dose is 0.25 mg per kg, and you can safely go to 12 to 15 milligram in an adult patient of the diltiazem. Even if it doesn't respond to diltiazem and verapamil, many of us do try IV amiodarone. Though amiodarone does not act very good on the AV node or AVRT, some people may do respond to the IV amiodarone bolus of usually 150 milligram. You have to give in 5% of dextrose, because if you give in saline, the chances of hypotension is more, and if you give in 5% dextrose, the chances of hypotension are less. So you should give always in a 5% dextrose over 5 to 10 minutes. However, still the patient does not respond, you have to give a synchronized cardioversion of around 200 joules. In a hemodynamic unstable patient, always the first choice will be a synchronized cardioversion. Now, one important thing is, most of this SVT, narrow QRS tachycardia, if you give adenosine, you will be able to make out the diagnosis. Like as I told in the last class, if they have a sudden termination, there are two only possible diagnoses, which is AV-NRT, which is the first diagnosis, and AV-RT, which is the second diagnosis. As I discussed last time, there is something known as the adenosine sensitive atrial tachycardia, which is very rare. So you should just keep in mind, but always remember, the sudden termination goes for AV-NRT and AV-RT, rarely sinus node re-entry. Now, if there is no change in rate, it means that it is due to a either a inadequate dose delivery, and you should always then consider that there are things like the other thing like a fascicular VT, narrow QRS tachycardia. Most of the time we have a RBBB type of morphology with a left axis deviation, and we think it's a narrow QRS tachycardia like SVT, but those are usually fascicular VT. Fascicular VT is usually seen in a structurally normal heart, 20 to 40 years of age, typical RBBB pattern with left axis deviation. Sometimes you may be able to see a AV dissociation. You should always consider if it is a gradual slowing and then again comes back to the normal, then the sinus tachycardia, inappropriate sinus tachycardia, or a focal atrial tachycardia, or a non-paroxysmal junctional tachycardia. So if there is a slowing and then patient comes back to the tachycardia again, then these are the differential diagnosis. One important thing is if there is a persistent atrial tachycardia with a transient AV block. If the patient develops AV block, we should always consider atrial tachycardia and atrial flutter. When we give adenosine, sometimes we may be able to make out the flutter waves, and then again it comes back to the tachycardia. So those things are usually goes for a atrial flutter. And if it reverts or if the tachycardia persists with the AV block, then you should know that the atrial tachycardia is likely. So this is how the response should be seen in a adenosine. Also, you should see whether the tachycardia terminates with a P wave or with a QRS wave. Last time, as I already told, if the regular QRS tachycardia terminates with a P wave, you should always rule out atrial tachycardia, because being P wave means AV node is a part of tachycardia, and in a atrial tachycardia, AV node is not a part of tachycardia. So you can always rule out atrial tachycardia if it terminates with a P wave. If it terminates with a QRS, then we cannot make out. So termination with a QRS doesn't help. Termination with a P wave usually means it rules out a atrial tachycardia. Now again, the same thing. Now suppose there is a regular SVT and you have reverted that, and then you see a pre-excitation rhythm. So we know the pre-excitation rhythm is when the WPW syndrome do not manifest, it is known as the pre-excitation. So a pre-excitation rhythm on the ECG, if you see, and the patient is willing and can be ablated, the first choice of treatment is always the EP study and the catheter ablation, and not the medical management. People who have one episode of even a SVT will be benefited from a catheter ablation, because lifelong you do not have to give drugs to those patients. Suppose the patient is not willing for ablation, then we have to try the medical management. So the first choice will always be a beta blocker like a propranolol or the metoprolol, and if you have contraindication like the bronchial asthma and other things, you can try calcium channel blocker like the diltiazem or the verapamil, which can also be useful. If the patient still doesn't respond to this group of drug, ideally you should again go for ablation. However, still if the patient is not willing and there is no structural heart disease, then you should try a flecainide or a propafenone. Most of the time flecainide usually we do not give for a SVT, but can be tried in SVT. Still, if the patient do not respond, we can still try amiodarone, dronidarone or sotalol, though they are not highly effective for patients with SVT. And the last choice of drug will be digoxin. But you should always should never give in the presence of pre-excitation. Now, some of the ablations which are can be cured with success with ablations are AVNRT, which has a success rate of almost 96 to 97%, and AVRT, that is accessory pathway, which has a success rate of 93%. Atrial flutter also has a success rate of 97%, but it should be CTI dependent. I'll come to it. We know that the atrial flutter can be cavo tricuspid ischemia. CTI means cavo tricuspid ischemia. They can have a clockwise or they can have a counterclockwise. We know the most common is counterclockwise around this junction, where they have a negative sawtooth wave in an inferior lead. That is the most common pattern. If it is a positive sawtooth appearance, it is a clockwise, and it is not very common. So if it is CTI dependent, the success rate with catheter ablation is very high. The success rate comes down if you have atrial tachycardia, junctional tachycardia, and a non-CTI dependent atrial flutter. Why the catheter ablation is the first choice, because the overall complications like the mortality and all is almost nil or 0% with the catheter ablation. Patient may need permanent pacemaker implantation, which is less than 1% of the time. So that is why it always remains a class 1 therapy for patients with SVT. Now let's discuss about the specific tachyarrhythmias. So the three important sinus tachyarrhythmias are physiological sinus tachycardia, inappropriate sinus tachycardia, and sinus road re-entrant tachycardia. We know that most of us can have physiological tachycardia if we are athletes and all can have. During the time of fever we can have. Sepsis patients can have a physiological or a inappropriate sinus tachycardia. Thyroid patients can have, patients with anemia can have, and any high outflow of output state can have. So all these things you have to rule out if you encounter a patient with a physiological or a inappropriate sinus tachycardia. Now, what is inappropriate is, as I already told you last time, the normal or appropriate sinus rate for a normal patient of 40 years will be 220 minus heart rate. That is the age. That is the 220 minus around age is 40, then it is 180. So if the patient can achieve 85% of if it is 85, more than 85% of the 180, then it is inappropriate sinus tachycardia. But for all practical reason, we say that any heart rate which is more than 130 to 140 is an inappropriate sinus tachycardia, because they may be associated with tachycardia mediated cardiomyopathy. So there should be a persistent increase in resting heart rate which is unrelated to the level of physical, emotional and pathological and pharmacological stress. And why does this happen is, as I already discussed in previous classes, the mechanism remains the automaticity. That is why the sympathetic things increase the rate of sinus tachycardia and the vagal things decrease the rate of tachycardia. And how do you diagnose is the presence of a persistent sinus tachycardia, heart rate more than 100 beats per minute during that day with excessive rate increase in response to activity and nocturnal normalization. So if you do a patient who complains of palpitation, a Holter monitoring, you see that the average rate on the Holter monitoring is always more than 100, and during the night time it comes back to the normal, because during sleep the vagal maneuvers are activated and the heart rate comes back to the normal. You should always remember that this tachycardia is non-paroxysmal, it is persistent, and that is why it is inappropriate sinus tachycardia. P wave morphology is always similar to the sinus rhythm because it is from the sinus, and you should always rule out secondary causes, as I already discussed. Now, how do you manage this? Is you should always evaluate and treat with the reversible causes. Second is, many of you would have been using this ivabradine. Ivabradine is a funny current channel inhibitor, and it works best for the sinus tachycardia. So ivabradine remains the first line of drug if you have a symptomatic inappropriate sinus tachycardia. Many a times we also advise patients beta blocker, because beta blockers are very useful for the anxiety related. So if somebody is anxious and he gets a palpitation and inappropriate sinus tachycardia, we can try giving propranolol, because it is lipophilic and it crosses the blood-brain barrier, and so the anxiety symptoms will also be relieved along with the tachycardia. So propranolol is always better than other drugs like the metoprolol and all. And the combination of beta blocker and ivabradine may be considered, but you should not try a combination. So ideally should try a ivabradine, which is the first line. You can go up to 7.5 milligram twice a day. So the maximum dose is 15 milligram of ivabradine. Ivabradine can sometimes produce symptoms like the yellow floaters in front of the eye. Those remains one of the common symptoms of ivabradine. So you should always remember that. Then the next sinus arrhythmia is the sinus node re-entrant tachycardia. Again, the tachycardia and symptoms are paroxysmal in this. They do not have persistent tachycardia, but the symptoms are paroxysmal. It is due to a micro re-entry. It is not due to the automaticity, but it is due to the re-entry. However, the P wave is identical to the sinus rhythm, and you should distinguish the sinus node re-entry from the sinus tachycardia, because sinus tachycardia is because of the automaticity, and I always discuss that automaticity have warming up and cooling down. So slow onset and slow offset is there, whereas the sinus node re-entry tachycardia is abrupt onset and abrupt offset because it is due to re-entry, and they have a longer RP interval than during the sinus interval. So if you have a sinus rhythm PR and you have a tachycardia ECG, the RP is usually longer than the sinus rhythm. They usually terminate with vagal maneuver and the adenosine. And the induction of arrhythmia is independent of the atrial or AV node conduction time. Not an important statement, but you should just remember this. Now, how do you treat this? There is no controlled trials of drug prophylaxis in patients with sinus node reentrant tachycardia. It responds well to vagal maneuvers, adenosine, amiodarone, beta blockers, and calcium channel blockers, and even digoxin. And EP studies may be done for patients who are frequently and poorly tolerated episodes. And radiofrequency ablation is generally successful in this group of patients. Now let's discuss the important topic of the day, which is the AVNRT, AVRT, and atrial flutter. Now, as I already discussed in the previous classes in the ECG, you can have a different morphology, but the most common morphology is the P waves are retrograde and inverted in 2-3 AVs, and the most common presentation remains you won't be able to see the P waves at all. That is 66% of the time. In 30% of the cases, you will be able to see a retrograde a P wave in the lead 3, which is known as the pseudo S, and V1, which is known as the pseudo R dash pattern, but that is seen in only 30%. Rest 10% presents with atypical AVNRT, that is long RP tachycardia. This is what I discussed. Those are the atypical AVNRT. Now, AVNRT, the treatment remains the same. If first you have to try the vagal maneuvers, carotid sinus massage, IV adenosine. 90% of the time, this will respond to IV adenosine. If it's the hemodynamically unstable patient, you have to give a cardioversion. If it is stable, then you have to give IV beta blocker like esmolol or the metoprolol, or IV diltiazem or verapamil, only if it is available. And finally, IV amiodarone. Amiodarone should be tried if patient is not responding to any other drugs. However, if you see that the patient rate is low, like 140 to 150, and patient is stable, you can always try those patients with oral beta blockers like metoprolol or the propranolol or the verapamil or diltiazem, and they will always be needed for the maintenance of sinus rhythm unless the patient is undergoing catheter ablation. The beauty of catheter ablation is once you do the catheter ablation, there is recurrence rate of hardly more than 2%, and most of this patient won't need any lifelong therapy. So as I told you, if the patient is symptomatic, you have to do then the first choice of therapy always remains the ablation, and it is the slow pathway. We know that there is slow pathway and there is a fast pathway. So it is the slow pathway which we have to ablate. And if the patient is not willing for the catheter ablation, then you should try beta blocker or the diltiazem and the verapamil. And if this is not effective and the patient is still not willing for a catheter ablation, we can try first the flecainide. The most commonly we use 50 milligram twice a day of flecainide, and then the next therapy will be amiodarone, sotalol, or the dofetilide or digoxin. But most of these patients should ideally undergo a catheter ablation. Now the next group of arrhythmia remains the AVRT. As I already told you, in this you will be able to see a clear-cut P wave in a tachycardia ECG, and it is a typical, like the RP interval is less than the PR interval, and the RP is usually more than 80 milliseconds. As I already discussed last time, the atypical AVRT, which is also known as the PJRT, is not seen in adult population. Most commonly it is seen in pediatric population, where they present with tachycardia cardiomyopathy, and if you terminate them, most of the time the LV function improves. This can be a concealed bypass, that they will always have an accessory pathway which can be concealed or the manifest. In most of the time, the concealed has only retrograde conduction from the accessory pathway, whereas the manifest will have both the antegrade and the retrograde. Now this manifest can be orthodromic or the antidromic. I have already discussed, but I'll come to it. But there are a few other ways by which AVRT can be distinguished by AVNRT. One is the electrical alternance, that during the tachycardia time, if you see an electrical QRS alternance, then it goes for AVRT, because the rate of AVRT is more than the AVNRT, and it is because of the rate that you get the electrical alternance. And the diffuse ST depression, that is again because of the rate. So the findings for AVRT will be a long RP, electrical alternance, and a diffuse ST, deep diffuse ST depression in the tachycardia ECG. As I told you, the orthodromic AVRT, which is more common than the antidromic, and the orthodromic are usually the narrow QRS tachycardia. Why? Because the antegrade is from the AV node to the ventricle, and the retrograde is from the ventricle via the accessory pathway to the AV node. That is why it is narrow QRS, because it is occurring via the slow pathway, which has a decreased refractory period. Whereas the antidromic one, the from the AV node to the ventricle, it goes via the accessory pathway, and because the accessory pathway is though a fast pathway, the refractory period is very high, and that is why the QRS is wide. They usually present with a wide QRS tachycardia, because the accessory, it goes down via the accessory pathway and comes back via the normal pathway, which is the slow pathway. So this thing is important, which is you should always remember. So again, the management remains the same of orthodromic, because they are a narrow QRS tachycardia, reverts with the vagal maneuvers and the adenosine. Success of still it is 80 to 90%, but lesser than that of AV-NRT. If the patient is hemodynamically unstable, then you should always do a cardioversion. However, if the patient is hemodynamically stable and you have a pre-existing pre-excitation on resting ECG, then the drug remains the same. That is the beta blocker, calcium channel blocker, that is the verapamil and diltiazem. And only if it doesn't revert, then you should try a synchronized cardioversion. But as I already discussed, in all the types of SVT, whether it be AV-NRT or AVRT, the first line of therapy always remains a catheter ablation. And only if the patient is not willing, then you should give drugs like the flecainide or propafenone, followed by amiodarone, beta blocker, calcium channel blocker, and the other drugs like sotalol and all. Now, what should you do in a patient with asymptomatic pre-excitation? Many a times you see this ECG, we have a tendency to localize the accessory pathway, and the patient is asymptomatic. So most of this asymptomatic patient should undergo a stress testing, exercise testing. In the exercise testing, if the pre-excitation disappears, it means it is associated with a good prognosis, and they are identified as low risk of patients. Also, if you have intermittent pre-excitation, so if you are seeing an ECG and you are seeing only few beats which are pre-excitation, again that has a good prognosis. So these two things suggest that there is a good prognosis in a patient with WPW. However, in all the asymptomatic patient with pre-excitation, so all this thing you have to do. An EP study is reasonable in asymptomatic patient, because if you during EP study, if you are able to induce the arrhythmias, it means you have to do a ablation of the accessory pathway. So that is something which is very important. Even the asymptomatic patient are ideally supposed to undergo a EP study for the inducing the arrhythmic events, and a catheter ablation for the accessory pathway is reasonable in asymptomatic if the EP study identifies a high risk arrhythmic event. So all the symptomatic patient, it's a class 1 to do a catheter ablation. Asymptomatic patient, only if during the EP study you are able to induce the arrhythmia, then you should be doing a catheter ablation. You will always be thinking there are many wide QRS tachycardia which are irregular, and that is usually AF with pre-excitation. So if a pre-excitation patient has a AF, usually it will be a wide QRS tachycardia and it will be irregular. In those group of patients, you should always remember that you should never give drugs which increase the conduction via the accessory pathway, like the beta blocker, calcium channel blocker, and digoxin. This drug increase the conduction from the accessory pathway, and they can change a AF with WPW into a ventricular fibrillation, ventricular flutter, and the patient may have a sudden collapse. So you should always use drugs like the propafenone or the procainamide, which decrease the conduction over the accessory pathway. However, the catheter ablation remains the first line of therapy in those group of patients. Now, another group of tachycardia is the junctional tachycardia. This junctional tachycardia can be paroxysmal and the non-paroxysmal. They usually arise from the AV node or the His bundle, and the heart rates are between 110 to 250. They are usually a narrow QRS or typical bundle branch block pattern. AV dissociation, this junctional tachycardia, that is also known as junctional ectopic tachycardia, it is usually not seen in adult patients. You usually seen in infancy or children after a surgery, after a congenital heart disease surgery for the congenital heart diseases, and many children with post-op. because of the hypothermia, they usually develop this that is known as the junctional ectopic tachycardia. It is a narrow QRS tachycardia which is usually irregular, and they have a AV dissociation. That is, the atrial rate may be lesser than the ventricular rate, but P and QRS are not related. And this is not usually seen in the adult population. It is due to the automaticity or the triggered activity. As you can see, this is a junctional ectopic tachycardia from a patient, and you can see that there is a AV dissociation. You can see the P waves here, and not in all the leads. So there is a AV dissociation, there is a narrow QRS tachycardia, and that is why it is a junctional ectopic tachycardia. Sometimes there are non-paroxysmal junctional tachycardia, which we see most of the time in adult patient, where you see there you won't be able to see a P wave, and many times it is seen post with a digitalis toxicity, or it can be seen after a cardiac surgery or electrolyte disturbances like the hypokalemia, and even in the setting of myocardial infarction. Many times we see this junctional tachycardia. The rate is usually 70 to 120 beats per minute, and it is because of the enhanced automaticity. So these things you should always remember. Now, if you have a junctional tachycardia, and the drug management includes beta blocker, again calcium channel blocker, and the second line remains the flecainide or the propafenone. And if it is not coming down or ineffective, then the patient can undergo the catheter ablation. But most of the time, they are due to the underlying diseases like one of these causes, and most of the time if you treat the cause, the patient will recover, or the patient will do well with the beta blockers or the calcium channel blocker. So for the junctional tachycardia, most of the time the catheter ablation may not be indicated. The next group of diseases are the focal atrial tachycardia and the multifocal atrial tachycardia. As I already discussed with you, the rates of atrial tachycardia are less than 250. They are relatively regular rhythm and sometimes can be irregular. Mechanism remains the automaticity most of the time, but they can have all three mechanisms like the ventricular tachycardia: automaticity, re-entry, and the trigger activity. The most common foci are in either the left atrium or in the pulmonary veins, same as in atrial fibrillation. And we can see them in myocardial infarction, non-ischemic heart disease, obstructive lung disease, electrolyte disorders, and the drug toxicity. So as I told you, most of the time, though it is regular, sometimes we may get irregular, and the RP interval is usually more than the PR interval. You can see a long RP interval. The P wave morphology is usually varying. So the P wave morphology may vary, and the PR interval may also vary. So these three things you should always remember. And if the patient is hemodynamically stable, the first line of therapy always remains the IV beta blocker or calcium channel blocker. They do not respond to adenosine. Very rarely they are adenosine sensitive atrial tachycardia, but it's very rare. So you should not try most of the time adenosine. You can just try a beta blocker or a calcium channel blocker. Only if it doesn't respond with that, you should try a adenosine. And if it doesn't revert, you should try a amiodarone, IV amiodarone or ibutylite. Most of the time we do not use ibutylite. You can try a IV amiodarone 150 mg bolus. In a hemodynamically unstable patient, you can try adenosine followed by a catheter cardioversion. So if there is a focal atrial tachycardia, always the first treatment remains the catheter ablation. Only if the patient is not willing, again the three group of drugs like the beta blockers and calcium channel blocker. Flecainide and propafenone, you should always remember, as I already discussed in the class of atrial fibrillation, in a patient with structurally heart disease, the drugs like flecainide, ibutylite, propafenone and all should never be used. So in those group of drugs, group of patients, you should only try amiodarone or the sotalol. So multifocal atrial tachycardia, all of you will be knowing, most of the COPD patients or the heart failure patients or people who are on drugs like theophylline and all, they usually have irregular RR interval, and there is a three different morphologies of P waves on the surface ECG. So there should be three different morphology of P waves on the surface ECG, and you will be able to see a distinct isoelectric period between the P waves. There are distinct isoelectric period between the P waves, and most of the time the RR, PR and the PP interval, all of this varies. They usually recover if you by the treatment of underlying condition. However, you should always try medical management if the patient is not able to recover. So you should be able to see 3 or more different morphology of P wave. Absence of one dominant atrial pacemaker. Atrial rate is more than 100. If it is less than 100, we usually call it wandering pacemaker. And the PP interval, PR interval, and RR interval all vary. Most of the time, if it is due to a COPD, you should always try calcium channel blockers like the verapamil or the diltiazem. However, if it's not due to COPD and heart failure, you can try IV or oral beta blocker, and most of these patients do well with the beta blocker and calcium channel blockers. Now, next about the atrial flutter, I have already discussed in the last class. Atrial flutter are usually due to a re-entrant circuit. They can be a micro re-entrant, they can be a macro re-entrant. And on ECG, you see something known as the flutter waves, which are the F waves. So they have a sawtooth appearance on the ECG. The ventricular rate is usually more, and the atrial rate is usually more than the ventricular rate, than that of a fibrillation, where the atrial rate is around 250 to 350. In atrial fibrillation, the atrial rate is around 200, 150 to 200. And you get a ventricular response which is usually regular, except in patients with atrial flutter with variable conduction. You may not be able to see a distinct P wave, and the QRS is normal with some aberrancy. So as I already told you, if it is a CTI dependent, that is cavo tricuspid isthmus dependent, it can be a counterclockwise or clockwise. Counterclockwise is most common, and you see a negative flutter waves in inferior lead. You can see a negative flutter waves in inferior lead, but it should be positive in lead B1. However, if it is a clockwise atrial flutter, which is also known as the atypical flutter, it is the opposite. So you see a positive flutter waves in inferior lead and negative in lead B1. This have a high tendency to be treated with the catheter ablation. So the success rate is very high in CTI dependent. Non-CTI dependent are usually atypical, and they can be from the right atrium or they can be from the left atrium, and the success of catheter ablation is usually very less in this group of patients. So a hemodynamically stable patient with atrial flutter, I just want to focus one point. The treatment strategy of atrial flutter remains the same as atrial fibrillation. So you have to do a rate control, you have to do a rhythm control, and you have to give anticoagulation in the same way as you are giving to a patient with atrial fibrillation. But the only one important thing is that catheter ablation, the success rate is very high in patients with flutter as compared to the fibrillation. So the rhythm control you should try with either a cardioversion or a IV ibutalide or a flecainide or those group of drugs. And for the rate control, we have both the beta blocker, calcium channel blocker, and the digoxin and the amiodarone. Then the stroke prevention, the therapy remains the same as atrial fibrillation. So as I already discussed, this is the way you have to manage a patient with flutter. How do you treat SVT in a pregnancy? You do the vagal maneuvers as recommended in a non-pregnant patients, and then adenosine is recommended for the acute treatment. Cardioversion can be given if the patient is hemodynamically unstable, and IV metoprolol or propranolol is reasonable for acute treatment in pregnant patients if it is not reverted with adenosine. So the next topic is the management of ventricular tachycardia. This is actually a more complex thing because it is not a very easy substrate as a SVT, and most of these patients have different. So we know, as I already discussed in the previous classes, how do you approach a patient with ventricular tachycardia? Because we know the wide QRS tachycardia, the most common differential diagnosis remains the ventricular tachycardia. If there is no structural heart disease, 8 out of the 10 times if you tell it a VT, you are right. In a patient who has a structural heart disease, if you tell 9 to 10 times out of 10, you will be right that it is a VT, because the other differential diagnosis remains a SVT with aberrancy, then a pacing rhythm, then a hyperkalemia, then drugs like class 1A and 1C drugs, and then the artifacts. So those are the other differential diagnosis of a wide QRS tachycardia. But the most common differential diagnosis remains the ventricular tachycardia. So there are various ways by which a ventricular arrhythmias are usually classified. The one of that is hemodynamically stable or unstable. So if the ventricular tachycardia is usually in a patient with structurally normal heart, there is no structural heart disease, then they usually present are asymptomatic or they have minimal symptoms like palpitation. Usually in the setting of a MI or a structural heart disease like HCM or ARVD or various other things which we are going to discuss, they may have a symptoms like a pre-syncope or a syncope. Many of them may present with sudden cardiac death, or some people may have sudden cardiac arrest or a resuscitated cardiac arrest. They are also classified by electrocardiology as non-sustained VT. We know that if you get a runs of broad QRS tachycardia lasting for less than 30 seconds, it is known as a non-sustained VT, and only if it is more than 30 seconds, then it is called a sustained VT. Both of this can either be a monomorphic and a polymorphic, which you can easily make out on a ECG. Monomorphic are usually the same morphology throughout. Polymorphic is usually a morphology which is different in the ECG. Then we can have something known as the bundle branch re-entrance tachycardia, which can be from the either a RBBB type or a LBBB type. Sometimes we can have a bidirectional ventricular tachycardia, which usually we see in patients with digitalis toxicity or a catecholuminergic polymorphic VT, or sometimes in aconite poisoning. So these are the three differential diagnoses of a bidirectional ventricular tachycardia. Sometimes we also see something known as a Torsades D point. So Torsades D point is usually sometimes things like a re-entry phase 3 or a phase that is a delayed after depolarization. You get Torsades D point. It can be because of hypoxia, hypokalemia, hypomagnesemia, acidosis, and sometimes even patients with bradycardia. Many patients with bradycardia can have a R on T phenomenon, and then it induces a Torsades D points. That is the way it is called Torsades D points, because there is a sudden change in the axis of the QRS complex. It rotates around its own axis, and then we can have ventricular flutter and ventricular fibrillation. If by the disease entity you see, then we have to discuss under the headings like a coronary artery disease in the patient with dilated cardiomyopathy with heart failure, and in the patients with congenital heart disease, in neurological disorders like myotonic dystrophy and all. Then in the patient with structural normal heart, that is known as the outflow tract VT or idiopathic VT, and then under cardiomyopathies like dilated ARVD, hypertrophic cardiomyopathy. So we are going to discuss this in the next 45 minutes, and I think we should all concentrate clearly, because each word may be important and will be asked in some form or the other. So the grossly you should divide it into a structurally abnormal heart, which is any cardiomyopathy or LV dysfunction, and in the structurally normal heart, which is the idiopathic VT. Idiopathic VT can be from the RVOT, from the left ventricular outflow tract, LVOT VT. They can be a catecholuminergic polymorphic VT. They can be a beta blocker or a propranolol responsive VT. So these are the different forms of VT in a structurally normal heart. So let's go to the VT in a structurally abnormal heart. Now, to see this, we will try to discuss it under the following topics like a coronary artery disease, cardiomyopathy with heart failure, bundle branch re-entrant VT, ARVD, which is a group of disease, hypertrophic cardiomyopathy, you will be well versed, and the VT after repair of the congenital heart disease. Now let's discuss VT in a coronary artery disease. Now you will be seeing many patients who present to emergency with a MI. Many patients just present with a ventricular tachycardia. They will have a polymorphic VT, they will have a cardiac arrest. You will be keep on resuscitating those group of patients. One thing which is important is always cardiovert the patient first. Any patient with a heart disease, if you are getting a wide QRS tachycardia, anything, just cardiovert the patient once, because most of them will be having a ventricular tachycardia polymorphic. If you are able to resuscitate the patient, you have to immediately take them to the cath lab. Now, how common the ventricular tachycardia is in a patient with coronary artery disease? In the previous trial with the people who were STEMI patients treated with thrombolysis, the VT was as common as 3.5%. So 3 to 4 patients out of 100 will have a ventricular tachycardia, and most of the time in acute MI it is the polymorphic VT. And in a patient with unstable angina and NSTEMI, it is not very common, it is less than 1%. So it is more common in presence of acute MI, because it can be various mechanisms like a re-entry or the automaticity. It can be triggered activity or the automaticity. Only in the patient who have acute MI, they have a polymorphic VT, which in a chronic MI, they have a scar VT because the scar is formed, and in the scar there is a re-entry. So in a patient who has a healed MI or a chronic MI, it is usually the monomorphic VT, which is due to a re-entry. In a acute MI, it is mainly the polymorphic VT, which is due to a automaticity or due to a triggered activity. We'll discuss this, but I just wanted to focus that one. And the clinical presentation may vary from tolerated sustained VT to certain cardiac death. Most of the patient in emergency, you see, they will be presenting with some patient will just come with a sudden cardiac death, and you won't know what has happened. So any patient who had a previous history of MI and comes to you broad dead in an emergency, the diagnosis is sudden cardiac death, and most of the time you have to think that it is because of a ventricular tachycardia. Some patient present with you with a resuscitated cardiac arrest, and again that is one of the important manifestations of a ventricular tachycardia. Otherwise the patient who presents with palpitation and all with a structurally heart disease are less common, and they will have significant hemodynamically instability. So if you see a sustained monomorphic VT within the first two days of MI, it is less common. More commonly, you will see a polymorphic VT. So monomorphic VT in the first 2 days of MI is very less common, only 3% of the cases, and it is usually associated with a high in-hospital mortality. A patient who doesn't have arrhythmia and a patient who has a VT, the patient with VT has a significantly higher mortality. And if the patient has survived for 30 days, then definitely the mortality is not increased at 1 year. So people who survived for 30 days have a good survival even at 1 year. Now, second is during the healing phase of MI, that is 2 days to around 90 days, that around 3 months. During this, it is associated with a reduced EF and is a predictor of worse prognosis. And this time, the monomorphic VTs are more commoner than the polymorphic VT. So polymorphic VT is only common during acute phase within 2 days, and after that the monomorphic VT is more common within the 3 months following MI. So that it has high mortality up to 40 to 50%. And which group of patients are at high mortality? One, anterior wall MI. Patient with anterior wall MI have a higher likelihood because LV function is less, they have a scar, so they have a focus for a re-entry. Second, people who have frequent episodes of sustained or non-sustained VT, people with heart failure and multi-vessel disease, and there are some vessels which are not revascularized. So those are the group of patients who have a higher mortality as compared to the other patient. And again, during the chronic phase, I told you, people may get VT after a MI up to many years, can occur up to 10 to 15 years after a MI, but the median time is 3 years. So many old patients which you see now comes with a VT, you are asked the history of MI is there. So that is the chronic phase, and that is the scar VT, which is the monomorphic VT, and all of them needs ICD for their treatment. Now the mechanism, as I already discussed, all the 3 mechanisms are possible. Re-entry is usually seen in a patient who have a scar. Otherwise, the other 2 mechanisms are common in a acute MI, that is the automaticity and the triggered activity. Automaticity is the VT arising from the ischemic border during the ischemia, and triggered activity is due to the ischemia due to the activation of ATP sensitive potassium channel, which causes a hyperkalemia. I'll discuss that. So during acute ischemia activates the ATP sensitive potassium channel, which causes a high extracellular potassium along with acidosis and hypoxia. And what does this extracellular potassium do is, it causes a greater resting depolarization, it decreases the conduction velocity, it decreases the action potential duration, and therefore it can cause early after depolarization. As I discussed in the mechanism of arrhythmia, anything which decreases the conduction velocity and decrease the action potential duration causes a early after depolarization, which can precipitate a ventricular tachycardia or a torsades D points. So it can cause a polymorphic VT. Now, during the healing phases of MI, as I already discussed, it is most of the time due to re-entry, and we know for a re-entry to occur, there should be a slow pathway and there should be a fast pathway. Normally from the AV node to the down, it usually goes via the slow pathway. It goes via the fast pathway, and only if the one of the path is blocked. You should have a unidirectional block in one of this pathway. So either there should be anatomical substrate, like a different refractory periods of the ventricular muscle or other thing, or it can be due to the functional is due to the different refractory periods, and anatomical is the presence of scar. As I already discussed, I just want you to focus on the 2 points. In a healing phase, the ventricular tachycardia is due to re-entry, and for the re-entry to occur, you should have a fast pathway, you should have a slow pathway. One of the pathways should be blocked so that it can go from the other pathway and it forms a re-entry. So that is one thing which is important. And you should have a substrate, and you should have a trigger. The trigger can be, in acute MI, the trigger can be ischemia, the trigger can be hypokalemia, hypomagnesemia, hypoxia, acidosis, or increased sympathetic tone, decreased parasympathetic tone, or heart failure decompensation. Any of this can be a trigger. And we should have a substrate also, and we should have a unidirectional block, and so these things are important. Now, how do they present? Most of the time they have mild symptoms, but any patient who have a coronary artery disease, most of these patients are usually symptomatic, and they present with pre-syncope or syncope, or they can have an exacerbation of angina during an episode, or heart failure. Because of the rapid heart rate, they may present with heart failure or a sudden collapse, like a sudden cardiac death or a resuscitated cardiac arrest. So the hemodynamic consequences depends on the ventricular rate. If the ventricular rate is slow, then it is fine. If it is very fast, they may present with collapse. Duration of VT. If the patient is on a hemodynamic, is in VT for a longer period of time, so the cerebral circulation will be low, and the patient will be hypotension and all. And the LV dysfunction. Patient with milder LV may not be that symptomatic and as compared to a severe LV dysfunction. And AV synchrony. Most of the time we know AV synchrony is important. So if the patient has an underlying atrial fibrillation, also you get a VT on the top of that. If the patient has a severe aortic stenosis or hypertrophic cardiomyopathy or any hypertension, the AV synchrony will be lost, and those patients are more symptomatic. So in an acute management, during if a patient of MI presents with you with a hemodynamic compromise, you should what always do is DC cardioversion. We know that the DC cardioversion should be, if it is a VF, it should be a non-synchronized. If it is VT, it should be a synchronized. It should fall, your cardioversion should fall on the QRS. In a VF, it should not fall on the QRS. So you have to give 200 joules of biphasic, 200 joules of cardioversion. What happens with the cardioversion is the refractoriness. The most of the fibers have different refractory period. So when you give a cardioversion, the refractory period becomes the same, and that is why it can revert a hemodynamically unstable VT. Now, if a patient after cardioverting, what you should do is you should try to maintain the rhythm with the amiodarone. Most of the patients with structural heart disease, the only drug which you can give is amiodarone. So you are giving amiodarone, you should start giving it first with a bolus. 150 milligram of bolus and 5% dextrose. The rate is 1 milligram per minute for 6 minutes, and then the 0.5 milligram per minute for 18 hours. So 6 hours it should be 1 milligram per minute, and for 18 hours it should be 0.5 milligram per minute. You should give at least for 24 to 48 hours the infusion. The patient should receive the loading dose of around 10 gram of amiodarone. Otherwise, the plasma T-half won't be achieved. And then after giving for 24 hours, you should convert it into 400 milligram thrice a day. And that you have to give for around 7 days. And after that, you can change it to 400 milligram twice a day. 200 milligram twice a day for a week. And then you should give the maintenance dose of 100 to 200 milligram. And that is how the amiodarone should be given. The loading dose of 10 grams should be there to maintain a good plasma T-half. We know there are too many toxicities of amiodarone. The short-term toxicities are the bradycardia. Most of the patients may have bradycardia, where you may have to stop amiodarone or you may have to decrease the dose of amiodarone. Some patients over long-term develop hypothyroidism, hyperthyroidism, corneal deposits, pulmonary fibrosis, or even hepatotoxicity. So these are the other complications of amiodarone. In many patients, if the patient is not responding to the amiodarone, you may have to give lignocaine. In many cases, lignocaine works only in ischemic VT, always remember. So only if an acute MI patient is presenting to you with a VT storm, which we will discuss sometime later, then the lignocaine works. Otherwise, the lignocaine doesn't work. How much lignocaine you have to give is 1 milligram per kg. We know 1 ml of lignocaine has around 21 milligrams. So you can easily give 2 to 3 milligram of 2 to 3 ml of lignocaine to the patient. And if the patient is responding to that, you can start an infusion of around 1 to 2 milligram per kg. So lignocaine works best in a ischemic VT as compared to a non-ischemic VT. Other drugs like procainamide and sotalol are alternatives, but they should not be used in patients with structural heart disease, severe LV dysfunction, and a patient with long QT syndrome or a long QT. So in those cases, sotalol is usually contraindicated. Always remember that if your patient is hemodynamically stable after a MI, one of the drugs which should be there is a beta blocker, which definitely has decreased in sudden cardiac death or a sudden death benefit from a sudden cardiac death. You should always treat the underlying condition like hypokalemia, hypomagnesemia. In acute MI, should always keep the potassium at 4, magnesium at 2. Any ischemia should be relieved. Heart failure should be well treated. And ICD, I will discuss when you should put the ICD. But what is the role of antiarrhythmic therapy? One, it decreases the frequency of ventricular arrhythmia. So if the patient has frequent ventricular arrhythmia, it decreases the frequency of ventricular arrhythmia. Suppose you have put a patient on ICD for a secondary prevention. So if a patient already has a VT, you have put a ICD. So it decreases the future risk of ventricular arrhythmia. Second, it decreases the rate of ventricular arrhythmia so that the patient has well tolerated ventricular test. So now the patient presented with a rate of 200. Next time the VT, the patient may present with rate of 100 to 150. So the patient may tolerate it better, and it may be treated with a cardio version or other drugs. And third, it decreases the other type of arrhythmias also, like the sinus tachycardia, AF or NSVT. So that is the role of antiarrhythmic therapy. Now, when do you send a patient for a catheter ablation? There are two indications. One is patient you have put a ICD, and even after putting the ICD, patient continues to have a ventricular tachycardia due to a scar. You should do a radiofrequency ablation and burn those scars. Second is in a patient with VT storm. VT storm, we know that there is 3 or more episode of ventricular VT which needs intervention to stop it. And if that is there in a refractory VT storm, you should always consider for catheter ablation. Now, when do you put ICD in CAD patient? There are two types of prevention. The most commonly we use secondary prevention is, suppose if a patient has ventricular tachycardia after a MI or during the first patient who has after 48 hours of MI, if develops a VT, it is usually a secondary prevention. If within 48 hours it develops a VT, it is due to the MI itself. You need not put ICD for all those cases, and most of the ventricular tachycardia disappears. But after a 48 hours, if the patient develops, it is most commonly for a secondary prevention, and most of these patients who develop VT 1 month to many years after a MI also is for secondary prevention. So all those cases, the ICD, intracardiac defibrillator, is indicated, who are the survivors of resuscitated cardiac arrest due to VF or a VT. Also, in a patient who have a cardiac arrest due to VF 48 hours after the MI, as I already discussed you, if you have treated all the other things like revascularization, electrolyte and all, if you have completely treated. Now, in primary prevention means which are the group of patients who should receive a ICD after a MI. So within 48 hours, if you get a VT, most of them do not need ICD. So if you follow up these patients, and if they have LV dysfunction less than 35% EF, and they have class 2 or class 3 symptom, and they have after 40 days, so any MI patient who doesn't have a VT, but you do an echo after 40 days, and the patient EF is still less than 35% on all the drugs, then you can consider for an ICD therapy. Again, if the patient who are 40 days after MI who have EF of 30% or less in NYHA class 1, so for a NYHA class 2 or 3, the cutoff is 35%, whereas for NYHA 1, the cutoff is 30%. Why? Because very likely that this patient will have a VT. So the chances are very high in VT people who have LV dysfunction less than 35%. Now let's go to the dilated cardiomyopathy. That is, this is non-ischemic cardiomyopathy. So most of these VTs in a coronary artery disease we have already discussed. One thing which I would like to discuss here is a VT storm. That is a separate topic, very small topic in Harrison, but I want to discuss it. VT storm is many patients you'll see you continue to have a VT. So if there are 3 or more episodes of VT which needs intervention, like a DC cardioversion within 24 hours, it is known as a VT storm. The VT storm is seen in many group of patients, but more commonly it is seen in disease like coronary artery disease or other diseases like the long QT syndrome, short QT syndrome, ARVD, sarcoidosis, or hypertrophic other diseases. So in most of the VT storm, as I already discussed, you have to give amiodarone and all, you can give lignocaine, but one thing is you have to remove the sympathetic drive. So the patient's sympathetic drive can be removed by 2 things. One is sedation. So always all the VT storm you should try to sedate the patient, because the sedation decreases the sympathetic activity. You can use intubation and general anesthesia like the ketamine, propofol, fentanyl. Any of the drug can be used, but most important is you have to decrease the sympathetic block, because sympathetic activation causes VT in most of these patients. Second is by drugs. So beta blockers should be an essential part of the drug therapy in all the patients with VT who have a electrical storm, and only after that you should consider drugs like a beta amiodarone. So amiodarone is a second line of therapy, and third line of therapy will be lignocaine in a patient who has a ischemia. In a patient with coronary artery disease and VT storm, lignocaine is the next group of drug. We know that the lignocaine is only IV and there is no oral form is there. So those patients can receive maxilitine, which has the same group of drug. It is a class 1A drug, maxilitine. So class 1B drug. So maxilitine can be used to substitute the IV lignocaine. Once you, or sometimes if the maxilitine is not available, even phenytoin can be used in this group of patients. So phenytoin and maxilitine can be substituted for IV lignocaine. In most of the patients, even after lignocaine and all, if they are not responding, the next therapy will usually be we do an anti-tachycardia pacing. You put a temporary pacemaker, and whenever the patient gets a VT, you have to increase the rate more than the VT rate. I told you already, this is known as the overdrive pacing, which causes the re-entry. It enters the cycle of the re-entry and it suppresses the ventricular tachycardia. So you can put a temporary pacemaker and do a pacing more than the ventricular rate, and it subsides the vent. If with any of this, if the VT is not subsiding, then there are other things like the catheter ablation and finally ICD. But unless the VT storm subsides, we should never put ICD. So there is one more therapy which is now coming up, is a stellate ganglia block. So you can do the stellate. We know the cervical sympathetic ganglia is one of the interesting field nowadays, and many people are using it for many diseases. So it can even be used in VT storm. People do sympathetic block. We know the sympathetic block is usually done by a experienced anesthesiologist, and the sympathetic ganglia you can block it either by a surgery where you do a surgical sympathectomy, and sometimes if it is not possible and you have to do in emergency, you can do bedside via ultrasound guided, and you have to give drugs like bupivacaine or ropivacaine to the sympathetic ganglia, which suppresses the ventricular tachycardia. So this is how you have to manage a patient with a VT storm. Most commonly it is seen in the setting of a coronary artery disease. Even in many patients who are on ICD therapy, even on patient on ICD also, many people do have a VT storm. So this is how you have to manage a patient with a VT storm. Now let us discuss a patient VT in a patient with dilated cardiomyopathy. So in a dilated cardiomyopathy, most of the time you have a non-sustained VT. That is VT which lasts for less than 30 seconds. It is usually seen in 80 to 90% of the cases. You can have multiform VPCs. VPCs can be more than one morphology. It can be in couplets or it can be in triplets. And ventricular arrhythmias are more frequent and complex as LV function worsens. And as the NYHA class worsens also, the ventricular tachycardia is more likely. The most of this usually arises from the myocardium, but there is one more group of VT which is seen in patients with dilated cardiomyopathy, is a bundle branch re-entrant VT. So apart from myocardial VT, there is something known as a bundle branch re-entry VT, which I will discuss in the next few slides, and it is due to macro re-entry. So most commonly in 60% of the cases, it's because of the myocardium. In 40% of the cases, it is due to the bundle branch re-entry. And what are the predictors of arrhythmia and mortality in patients with a dilated cardiomyopathy are: one, severity of LV dysfunction. I told you, as the LV dysfunction worsens, they have more VT and arrhythmia. As the CCR, patients who have a decompensated or advanced heart failure have more likely to develop a VT. If the history of syncope is there, then they have high chances of mortality. If they have high NYHA class, as you can see in this, the chances of sudden cardiac death is more. In the laboratory parameter, if they have a low sodium level and if they have high sympathetic levels like the norepinephrine, renin, or the BNP levels, then they have high chances of sudden cardiac death. ECG predictors are LBBB morphology and the first or a second degree AV block. So if these blocks are there, the chances of ventricular tachycardia and a sudden cardiac death is high. And during the EP study, which we may not know in detail, so if an inducible VT is there in a patient with dilated cardiomyopathy, they are at high risk for sudden cardiac death. Now, do the drug therapy have any role in dilated cardiomyopathy? We know that beta blocker is one drug which has been tried in most of the trials, and it has a significant role in decreasing the sudden cardiac death. So in the carvedilol was tried in many trials. CBIS, the bisoprolol drug was tried. In MERIT-HF, the metoprolol drug was tried. So these are the trials which were done in the patient with non-ischemic cardiomyopathy, and they showed that beta blocker has a significant role in the decreasing the sudden cardiac death, and the number needed to treat was around 22 to 25. So if you treat 22 to 25 patients, you can prevent one mortality in patient with dilated cardiomyopathy. And what about the ACE inhibitors and the ARB? We know that ACE and ARB can improve survival, but the data are very conflicting in sudden cardiac death. Trials like the Consensus, SALT and SAVE, they did not show any reduction. Other trials like the VHEPT or TRACE and AIR, I don't want you to go in detail, but you should just remember that there are few studies which show that ACE and ARB show decreased sudden cardiac death, but there are other studies which show that there was no decrease in sudden cardiac death. Aldosterone antagonists definitely have a role in decreasing the sudden cardiac death in patients with a dilated cardiomyopathy, and we should know that the digoxin has a pro-arrhythmic effect. Most of the time we should not use it because the DIP trial had come which showed that there is no significant mortality benefit, and even it increases the mortality in a some subgroup of patients like in women. So the meta-analysis has shown that the digoxin has a pro-arrhythmic effect and should not be used for decreasing the sudden cardiac death risk. Now the indication for ICD remains the same. For a primary prevention, all patients with non-ischemic dilated cardiomyopathy who have a EF of less than 35% in NYHA class 2 or 3, you have to put ICD, and in a NYHA class 1 if the EF is less than 30. Patients who have a resuscitated cardiac arrest and they are secondary prevention, and ICD is definite. However, if you have an unexplained syncope, significant LV dysfunction and non-ischemic DCM also, you are justified in putting a ICD in this group of patients.
I didn't catch that.
Now, let's go to some a word about a bundle branch reentrant. Harrison has mentioned a paragraph on bundle branch reentrant, so it is something which you should remember. We know that from the AV note, from his bundle, there is right bundle and there is a left bundle. The left bundle divides into left anterior fascicle and the left posterior fascicle. So sometimes because of the severe LV dysfunction and all, because of the scar and the macro re-entry, because of the re-entry, there can occur the re-entry along this, and patient can have a bundle branch re-entrant tachycardia. Now it is the left LBBB morphology which is more commoner than the RBBB morphology. So in a patient monomorphic VTs, if you see 100 monomorphic VT, only 6% will have a bundle branch re-entry. So it is not that very common. And others 25% will have a myocardial VT. It is very commonly seen in patients with dilated cardiomyopathy. I told 60% will have a myocardial VT, whereas 40% will have a bundle branch re-entry VT. However, it is not only common in dilated cardiomyopathy, it can also be seen in ischemic cardiomyopathy where the incidence is less, 4.5 to 6%, and in patients with valvular heart disease, but it is usually seen after surgery because during the surgery there can be a trauma to the bundle branch or his bundle which may cause a bundle branch re-entry VT. patients with congenital heart disease like Epstein's anomaly, hypertrophic cardiomyopathy, neurological disease like myotonic dystrophy, and other conduction anomalies with sodium blockade with flecainide can be associated with bundle branch re-entry. As you can see this, there are three types of bundle branch re-entry. You should always remember that the LBBB morphology. So the typical ECG of when you see a LBBB morphology and a left axis deviation, the first, apart from you should always consider the diagnosis of a bundle. Normally we know that a normal VT will have a LBBB morphology with a right axis deviation, but a bundle branch block re-entry VT has a LBBB morphology with a left axis deviation. So that is something which you should know. The RBBB morphologies are less common than LBBB morphologies. In LBBB morphology, the antegrade conduction occurs via the right bundle and the retrograde conduction occurs via the left bundle. So that is something which you should know. They are usually, and most important thing is, they are usually unstable, very high ventricular rate, 200 to 300, and you may have to give a cardioversion to stabilize them. And most of them present with syncope or cardiac arrest. If you have a baseline ECG, most of them will have a sinus rhythm or some form of non-specific intraventricular conduction delay or a PR prolongation. Typical bundle branch pattern may also be seen, like LBBB morphology may also be seen. And ECG during ventricular tachycardia, I already told you, LBBB morphology with left axis deviation is the rule, because most of the VTs who have LBBB morphology will have a right axis deviation. So this is how you can differentiate it from the typical VTs. Treatment: the pharmacological therapy is usually ineffective in a bundle branch re-entry VT. The treatment is the radio frequency ablation. Most of the time you have to ablate the right bundle because that is very easier. The left bundle is preferred in a different subset of patient. Suppose if you have a bundle branch VT and if you have an infrahesian conduction block in the form of AV block where the HV interval is more than 100 milliseconds, in those group of patients you may have to put a pacemaker. Now let's go to a next subgroup. So I just wanted to highlight on what is the bundle branch re-entry VT. How do they present? How do the ECG look? Where are they commoner? More common in dilated cardiomyopathy, rare in ischemic cardiomyopathy. They can be present in other group of patient also, and they are not do not respond better to drugs. Radiofrequency ablation remains the first choice of therapy. Now let's go discuss about a patient with a arrhythmogenic right ventricular dysplasia. I am not sure whether you would have seen this group of patients because it is a form of a genetic group of diseases which are usually autosomal recessive, can be autosomal dominant also, and it is usually most commonly seen in RV. RV involvement is seen in maximum group of patients. LV involvement is seen only in 20 to 30% patient, and that is why it is known as arrhythmogenic right ventricular dysplasia. It is usually seen in young adult people less than 40 years of age, 80% of the patient, and more common in male population compared to the female population. Very rare disease, and it usually involves the triangle of dysplasia. So there is something known as the triangle of dysplasia in the RV, and where the RV myocardium is replaced by the fibrofatty tissue. So there is an obliteration of the RV apex. As I told you, it is usually a familial disease and mostly can be autosomal dominant and the recessive, and there are mutations in the desmosomal protein like the desmoglein, desmoplakin, desmocholine, or the plakoglobin and the plakophilin. You may get it in your multiple choice, the types of mutation, but it is usually a familial disease with a autosomal dominant or recessive. Very rarely can be due to metabolic or infectious, which you should not think of. There are some syndromes which are usually associated with autosomal recessive pattern, which is known as the Nexus disease, or there can be familial palmoplantar keratosis, thickened skin on the palmar and the plantar region, and they can have keratosis. And sometimes the Nexus disease, they can have a woolly hairs. Cardiac anomaly, RV involvement is seen almost in 100% and the LV involvement is seen in 27% patients. So it is more commonly a RV involvement which is seen. The mechanism of arrhythmia is usually the re-entrant VT. So you should remember the mechanism of arrhythmia is re-entry. And how do they present? Most of this patient presents with exercise-induced VT. So ARVD usually present by a exercise-induced VT, and if you have a severe disease, 100% will have a ventricular arrhythmia, as compared to if you have a milder disease where have a 23%. So other patients do present with a heart failure symptoms, or with a syncope, or with a palpitation, or a atypical chest pain. Now, who are at increased risk for sudden cardiac death are younger patients, patients with recurrent syncope, with a previous history of cardiac arrest, patients with LV involvement, patients who have a ARVD2 or a Nexus disease, and patients with increasing QRS dispersion. So these are the group of patients who are at increased risk of sudden cardiac death. Now, in ECG, I think one of the things which you always will be seeing is a epsilon wave. Many of you would have heard about the epsilon waves on ECG, and it is usually seen in patients with ARVD. Now, what is the epsilon wave? Is you see a typical morphology of epsilon wave in lead V1 to V3. You get it, and this is known as a epsilon wave. Usually this people present with LBBB morphology of VT because they usually arise in the right ventricle, and because they arise from the RV apex, you can have both the superior axis and the inferior axis. But because it is the it arises from the RV apex, you get a negative QRS in the inferior lead. Because it is not a RV outflow tract, most of them arises from the RV apex. So the usually LBBB morphology, and because they arise from the apex, it goes towards the RVOT, so the inferior lead will be negative. But they can have positive also rarely. Now, what are the usually typical diagnostic criteria of ARVD? As I told you, you can have severe RV dilatation, and RV ejection fraction will be reduced. RV can have aneurysm, RV can have dyskinetic areas. So these are the various major criteria. There is a fibrofatty replacement of the myocardium, and repolarization abnormality in the form of inverted T waves in the lead V2 and the V3. And then you can have a epsilon waves on the ECG in lead V1 to V3. You have a LBBB type of VT, which can be sustained or non-sustained, and you can do a Holter monitoring for those group of patients. If family history is there, then it can be very definite. We see the various echo parameters where we see that the RV ejection fraction is reduced, and RV OT, that is right ventricular outflow tract, is dilated in this group of patients. Now, how do you manage it? Now, if the patient presents with a ventricular tachycardia, or if there is a history of resuscitated cardiac arrest, or if there is a family history, all these patients should definitely receive a ICD. So patient who has a documented VT or a resuscitated cardiac arrest, or even a history of syncope, or a family history is there, those patients should ideally receive a ICD. Now, after receiving IC, radiofrequency ablation is usually not successful because the RV is diffusely involved. You cannot go and ablate all those areas. So first therapy remains the ICD. Only if the patient continues to have VT on the top of ICD, then the radiofrequency ablation can be tried. Otherwise, the success of radiofrequency ablation is less in this group of patients. There is no such role of pharmacological therapy, because only if a patient presents with ARVD to you with symptoms of in acute phase, then there is a role of beta blocker amiodarone. Otherwise, you have to decide on the standard therapy like a radiofrequency ablation or a ICD. Now, one important group remains the VT in patients with HCM. You know this disease very well. HCM, you will be knowing it. The patient with HCM, they have a mortality rate of 1% per year, and the sudden cardiac death is around 0.2% per year. Now, which are the group of patients who are at risk for sudden cardiac death? Now, if a patient who has a family history of sudden cardiac death or out of hospital cardiac arrest, for those are the group of patients which are at risk for sudden cardiac death. If they have a sustained VT or a ventricular fibrillation, those are at increased risk. Family history is there, then there is increased risk. If the LV thickness is more than 30 mm, If the thickness is more than 30 mm, then they are at increased risk. If they have a on Holter monitoring non-sustained VT, they are at increased risk. Normally, if you make them run on an exercise, if they have a hypotensive response in an exercise, they are at increased risk. If they have an unexplained syncope, also they are at increased risk. And if you do an MRI in a patient with hypertrophic cardiomyopathy and you see a scarring, that is the late gadolinium enhancement, which is more than 15%, then they are at high risk. If you need two or more, not one, two or more of the above parameters, then those are patients who should receive ICD for a primary prevention. And all other patients who with HCM who have a documented VT or who have a resuscitated cardiac arrest, they should receive ICD for a secondary prevention. So this is one thing which I already told you. Now there are many congenital heart disease, mainly the tetralogy of Fallot. We operate for intracardiac repair. We know that there are many approaches for repair, like the RV approach and all. Because we put an incision on the heart, so after a surgery, they are at high risk for ventricular tachycardias. And which are the group of patients who are at high risk for sudden cardiac death after that is, if the QRS duration is more than 180 milliseconds, if there is a rapid increase in QRS, so all these patients, you should follow up every yearly and do their ECG after a TOF repair. And if you have a dispersion of QRS duration, increase QT interval, if they have a complete heart block, or if the surgery is done at a later age, that is after 10 years, if you have a RV dysfunction, or if you have a tricuspid regurgitation which is progressive, and if you have RVOT aneurysm. So these are the risk factors for sudden cardiac death and VT. Not all of them you will put ICD, but if they are at risk factors, and if the more than two or more risk factors are there, then you should definitely consider for ICD in this group of patients.